Good afternoon. I wanted to thank Dr. Druridge for inviting me to speak today. I think I'm the only radiologist, feeling a little bit outnumbered, but it's okay. So Dr. Liu's talk really goes very well with this one. You'll see that they complement each other. As everybody knows here, that the majority of tumors in the head and neck are squamous cell carcinoma, so that's going to be the emphasis of my talk. And by looking at the anatomy on imaging, I'm going to show you the patterns of tumor spread, which is obviously going to influence your treatment planning. And we're going to talk a little bit about the role of CT, MRI, and PET in some of these subsites that I'm going to bring up, and then we'll talk a little bit about the post-therapy assessments. So I think most of you are aware, and as Dr. Liu also showed you, that mucosal disease is what you see on clinical examination. It is what we do not see well on imaging, so that's not the imager's job. If you see it mucosally, it's real. I'm going to miss it a lot of the times, but where I can help you is for the deep extent. As it goes submucosal, is there carotid encasement? Is it in the bone? Is there perineural spread? Are there sub-centimeter sized nodal metastases? And so everybody always asks me, you know, Dr. Stambuk, what should I use? I want one scan for everything, CT versus MRI. And I mean, here we go. It's not mutually exclusive. I'm going to show you examples of why one's better than in one scenario, one better than the other, but sometimes they can actually complement each other depending on the question. And it's so important to understand what CT or MRI or PET can answer for you so you order the right study and that you know that you're satisfied with your results because the question could be answered by that imaging modality. So I like CT a lot in head and neck, not for all subsites, but for a lot of them, simply because patients have a hard time when they have cancers in their base of tongue, oral cavity, larynx, bulky tumors, lying flat down, saliva pooling, they're coughing, they can't lie still. And CT, once you set them up, they can be scanned in less than 60 seconds. So you're going to have a lot less motion artifact. And then you can do any reformation you want, sagittal, coronal, obliques, or whatever. I really think CT is superior for fine cortical bone detail. So for example, in the oral cavity, when tumors go directly into bone, they go to the cortical surface first, as opposed to nasopharynx that you'll see in the medullary space. So in oral cavity, you'll see early cortical erosions in the bone that you'll miss on MRI. Also, if you see early extracapsular spread of disease, which is a bad prognostic feature, it's first seen on CT far before it's seen on MRI or on clinical examination. But you know, nobody's perfect. CT's not perfect, and we're all very familiar with this beam hardening artifact from dental amalgam. There are ways to angle around it, but sometimes you just can't get a good view of the site that you're looking at. MRI obviously has its advantages as well, and I'm going to stop right here and tell you, even though I like CT and I like MRI, I will tell you that it's imperative to have MRI for nasopharynx and hard palate tumors. And well, why is that? Well, MRI is superior because it shows you tumor muscle interface well. Well, that's good for all subsites. But nasopharynx and hard palate tumors have a propensity for perineural spread of disease, and that's where MRI excels CT. When hard palate tumors grow north, they can go into the maxillary sinus, and you can easily on MRI see tumor versus post-obstructive disease. That's not as easily done on CT, and that's the advantage of MRI in that scenario. But again, nobody's perfect. Here's a patient with a large base of tongue tumor. MRI would have been beautiful, but they're coughing and moving, and this is a non-diagnostic study. So even though you say, I really want an MRI on this certain scenario, this patient, if you know that they can't lie still in a magnet, don't waste your time. Go ahead and send them to CT, because it's better to get something that you can plan from than a mess and a wishful hope. So it's important to know your patients as well. So I wanted to go through various subsites. I'm going to show you some imaging. First, we're going to start with the nasopharynx because that is primarily treated by radiation therapy. There's a lot of spread patterns, but instead of showing you the words, we're going to go through various images. So this is a young patient. This is like an 11 or 12-year-old patient with nasopharyngeal carcinoma, which doesn't seem real, right? But I wanted to remind everybody, even though nasopharyngeal carcinoma is primarily an adult disease, it can be seen in adolescence, as you can see in this patient. So looking at normal anatomy, this is the fossa of Rosenmuller, this is the posterior nasopharynx, this is left fossa of Rosenmuller, and you can see that there's an asymmetric soft tissue mask in the posterior lateral nasopharynx. Because the eustachian tube is compressed by the mass effect from this tumor, the middle ear cavity and mastoid air cells can't drain. So what does that mean? Well, if you look at the opposite side, the mastoid air cells here are air-filled, just like this lumen. They're nice and black. But on the opposite side, because the eustachian tube is blocked and it can't drain, you can see that there's fluid and mucosal change building up in the mastoid air cells. So in an adult, even if you're getting a brain MRI and you don't expect this, you've seen asymmetric mass in the nasopharynx and unilateral pacification of the mastoid air cells, you really should be thinking nasopharyngeal carcinoma, again, in an adult. After I look for the asymmetric mass and I look for the mastoid opacification, the next thing I want to look for is skull base invasion. And the beauty of MRI in this scenario is that in adults, the marrow is fatty white. And when you see tumor infiltrating, you see ventrally, here's the asymmetric mass, there's a primary tumor. You can see gray tumor infiltrating the fatty white bone, and this is why I love pre-contrast T1 weighted imaging when I'm looking at head and neck cancers, particularly in the bone. Sometimes if you're lucky, the tumor infiltration can be T2 bright, but I wouldn't depend on it. But do notice that they do have a pacification of the mastoid air cells. You can do a post-contrast fat-SAT image, and what does that do? Well, the fatty marrow that we saw originally suppresses, and you can see the enhancing tumor. So you're thinking, why don't I just use this sequence? Well, because the head has such a variable shape, and it's a different size and shape than the neck, and the neck than the chest, you can see that we can have distortions and you can get incomplete suppression of fat. And why am I telling you this? Well, look at this right here. If you can see that the subcutaneous fat ventrally did not suppress, but it did out laterally, you can see that there's incomplete, inhomogeneous suppression. So what if this patient's tumor and what if the bone back here didn't suppress well? I might overcall bone invasion when it didn't exist. So post-contrast fat-SAT is nice, but I really like the pre-contrast T1 for bone invasion. I like to see it on two views, and one of my more favorite views is the sagittal. I lift off of it. If you look on the pre-contrast T1 weighted image, here's the clivus. Nice fatty marrow dorsally, but ventrally it's replaced by gray tumor. If you just look at the post-contrast image, this is the exact same patient. Look how the tumor enhances. You're going to miss skull base invasion. Okay. So I just showed you asymmetric mass in the nasopharynx, opacification of the mastoid air cell on the same side. Why does the tumor go into the skull base? Well, instead of laterally. Like, why don't we see the tumor spreading out like this? Why is it going up? Well, we all remember from medical school the pharyngobasilar fascia. It's a tough aponeurosis that actually contains tumor and acts as a barrier to spread laterally. So which way is a tumor going to grow? If it can't grow this way, it's going to go up. So if you look at this case, you can see there's a large nasopharyngeal tumor, and if you see here's V3, not involved at all, nor are the infratemporal fossa structures because the pharyngobasilar fascia is intact. So this patient is spared perineural spread of disease with no tumor jumping on V3 in the infratemporal fossa. So where is the attachment of the pharyngobasilar fascia? This is an upside down view of the skull, and you can see that it attaches medial to the foramen ovale, and that's how it spares V3. And the pharyngobasilar fascia runs from skull base down into the thoracic inlet. So let's look at this case right here. This is eustachian tube orifices here. This is the torus tuberous. Normal fossa of Rosenmuller, well, kind of normal. This is clearly abnormal asymmetric soft tissue mass. Look at the pharyngobasilar fascia stopping the tumor from going laterally, sparing the fat, and this is V3. V3 is left alone, no perineural spread, and no perineural spread here. So good for this patient, but we're not done. So I said the tumor's not going to go laterally, but it likes to go north. Well, there are other things in bone that's north of the nasopharynx. If you look on this coronal pre-contrast T1 weighted image, I can already see there's a problem. Look at the fatty medullary space, the marrow of the skull base, and if you look centrally, you can see that this fatty marrow is replaced. This is Meckel's cave. Even without contrast, I can see the opposite side's already in trouble. It's soft tissue filled, as is the bone bilaterally. So let's look at an axial post-contrast fat-SAT, and you can see that the tumor is going through the skull base and it's around the carotids. It's actually already jumped on V3 intracranially and made its way into the cavernous sinus and into Meckel's cave. So that's another route of tumor spread. So where else do we look for tumor spread? Well, the first place that the lymph nodes drain in nasopharyngeal carcinoma are the lateral retropharyngeal lymph nodes, the nodes of Rouvier. And where do you find it? But between the internal carotid artery and the prevertebral musculature. Here's a normal node. Now, if you look at this opposite side, I agree this is a very ugly MRI, but there's a reason. This node is too big in an adult. I don't like it to be more than 8 millimeters in size, but I don't only go by size, I go by round morphology. And look at this gross infiltration of the muscle and the adjacent soft tissues. This is extra capsular spread of disease. So this patient presented with a cranial nerve neuropathy because 9, 10, 11, and 12 live around that area. Now, I told you the pharyngobasilar fascia stops the tumor from going laterally, but it eventually does break down. You can see this big nasopharyngeal tumor. Look at the parapharyngeal fat on the opposite side on this CT. It's nice and black. If you look on the right side, you can see this finger-like projections in it. So you don't have to have a ball going into the parapharyngeal fat. That's just tumor, like little fingers going into the parapharyngeal fat, and that's gone beyond the pharyngobasilar fascia. As the tumors become more advanced, they can grow anteriorly into the nasal cavity. And don't forget that there's a connection to the infratemporal fossa, the sphenopalatine foramen, which gives tumor access to an area called the pterygopalatine fossa. I'm going to go over the pterygopalatine fossa maybe 1,000 times in this lecture to help you understand it well. This is a very nerve-rich area. This canal runs from the orbit down to the hard palate, gives you access laterally and immediately into the nasopharynx. Notice that this tumor that went into the pterygopalatine fossa, you've got widening of the bony canal as opposed to the opposite side. Now, this is a very advanced tumor. It's a big tumor, skull base invasion, beyond the pharyngobasilar fascia into the parapharyngeal fat, but also into the pterygoid muscles and a little bit in the masseter. This is very advanced stage. So I wanted to show you this case that was actually brought to me by one of my surgeons. This patient was told they had bulky lymphadenopathy, bilateral neck, and they were told they had lymphoma and they need to go to Memorial Sloan Kettering. So they were seen by one of our head and neck surgeons. He's like, Hilda, they're telling me this patient has lymphoma. It doesn't look like lymphoma to me. And all these images I'm going to show you are from an outside institution. So the first thing I notice is, yes, there's bulky lymphadenopathy in the neck bilaterally, even in level 5. So knowing that there's bilateral neck disease, including level 5, that's classic nasopharyngeal carcinoma. So that's what I'm thinking immediately. It could be lymphoma, except there is gross extracapsular spread of disease from these lymph nodes. And lymphoma generally, when it presents, are beautiful, fat, well-defined lymph nodes, no extracapsular spread of disease. So I'm thinking this is more of a pattern of nasopharyngeal carcinoma. So the first thing I did is on their outside scan, I looked at the clivus on the CT, and when you see this much bone involvement, it could be lytic, it can be sclerotic. This happens to be sclerotic. That's a lot of bone involvement. You can even see a bite is out of the clivus itself. It's way more dense than the rest of the vertebrae and bones that you see. If you don't believe it, look at the pre-contrast sagittal T1, look at the fatty marrow in C2 and C3, and in the clivus is completely replaced by tumor. Again, nasopharyngeal carcinoma, so where's the primary? If I look at the CT, I have to be honest, I have a little hard time with that, but the MRI is very, very compelling. The rule of thumb for mucosa and the oropharynx, nasopharynx, hypopharynx is you should be able to take a sharpened pencil lead and be able to draw the enhancing mucosa, because mucosa should enhance. So let's look at the left side. Nice mucosa, nice thin uniform, fossa rosemuller going to the back. This is way too thick. Granted, it's a small tumor, but it's a definite tumor. They took this patient to the OR, did a biopsy, and they found that's where the primary site was. So this patient also came with a PET. So I want to incorporate in this talk, PET's wonderful, but I'm going to show you ways that we can trip, because it helps in many ways, but I want to keep you out of trouble when it can be a trip up too. So here's this patient's PET from the outside. You can see there's bulky disease, bilaterally, level 5. We should be thinking nasopharynx. But notice that the clivus is very FDG avid, so how was this missed? And I want to propose to you that possibly when you're looking at 1,000 images on PET, because they do the whole body, that this probably was confused with brainstem. So don't make that mistake. I see that a lot, clivus, FDG avid with various tumors, and you're looking at images fast and you think it's brainstem. Okay, next I'm going to go to oropharynx. Dr. Liu already told you the anatomy is the posterior 1/3 of the tongue where all the lingual tonsil is and part of the tongue itself. You also have the soft palate and the paired palatine tonsils. I'm going to show you a big example of a tumor just so we can go over the anatomy. This right palatine tonsil is obviously larger than the left, so this is where the primary tumor is. It's involving the soft palate, which is super important to evaluate when you're looking for a patient who may have torus surgery or versus radiation therapy. How do I know I'm at the soft palate? Well, look at this bridge of soft tissue between the tonsil bilaterally. This is the soft palate. Now, what you do is you're going to look north and see if it goes in the nasopharynx, which it can. It doesn't often, but it can. But tumors tend to gravitate, go inferiorly. So we're going to follow this CT scan. You can see this bulky tumor going along the posterior pharyngeal wall, and now it's going into the glossotonsillar sulcus towards the base of tongue. The reason why I want to show this study to you is that tonsil tumors commonly present with level 2, if not more, 3 and 4 lymphadenopathy. And here's a level 2 lymph node. Here's the primary tonsil lesion. Here's the poor little internal carotid artery stuck in the middle. And you can see as these tumors grow, the nodal met as well as the primary, you can quickly get carotid encasement and carotid blowout. And that's why it's the primary tonsil tumors that are more susceptible to carotid invasion and a blowout. I wanted to show you this left base of tongue tumor and to remind you guys that on CT, squamous cell carcinoma doesn't always enhance a lot, and a lot of times it doesn't. So what we're looking for is asymmetric soft tissue, and I think you can see it very nicely here, left base of tongue, lateral pharyngeal wall, and actually going on the left posterior pharyngeal wall. So you want to follow the tumor up into the tonsil. It didn't go that way, so let's work our way down. This is tumor making its way into the vallecula. Here is the epiglottis. You think you're done, but you're not. Here we are in the larynx. This is a supraglottic larynx. You can see the AE folds. Here's the piriform sinus. Let's take that sharpened pencil lead, beautiful mucosal enhancement, nice and thin, making my way around, and wow, this is way too thick in the left piriform sinus. This is tumor extension into the left hypopharynx. You need to recognize it so the patient gets appropriate treatment. Okay, I love sagittal imaging when it comes to base of tongue tumors, and here's one of the reasons. Here's a nice base of tongue tumor. Here's the epiglottis. You can see it's being pushed back. The mucosa is not involved. It's just the tumor's exophytic pushing the epiglottis posteriorly. I want to introduce you to the hyoepiglottic ligament. It's a very important ligament. It's a barrier for tumor spread. It runs from the hyoid bone to the epiglottis, and this is also a very important ligament for tumor spread barrier for supraglottic tumors as well. So you can see that the tumors course down the base of tongue, make its way into the vallecula, but because of the hyoepiglottic ligament, it does not go into the preepiglottic fat, generally. But this is what you look for. See, there's sparing of the preepiglottic fat here. Okay, another base of tongue tumor. We're feeling good. We know where the tumor is. We can see the bilateral neck nodal disease. Look at this nice sagittal image that shows you the base of tongue tumor. Not only is it going down into the vallecula, but look at this soft tissue thickening on the lingual surface of the epiglottis. All right, so that's going to increase the stage of the tumor. And you need it for your treatment planning to recognize this. This is another patient that was brought to us that was thought to have a T2 tonsil tumor. They were treated on the outside. It looks like a generic right palatine tonsil tumor. It looks, it's what you normally see, bread and butter. Look at the opposite side, the left tonsil looks great. But if you look north, we looked for the nasopharynx, soft palate not involved. They looked down, it didn't go down into the hypopharynx. But now we got to look forward into the oral cavity. And here's a muscle, a normal muscle called the hyoglossus muscle. And you can see, even if you don't know your anatomy, you can see that this is asymmetric relative to the opposite side. This tumor is tracking into the extrinsic muscle of the tongue, the hyoglossus muscle, and it's a very important tumor. This makes this patient T4. But this muscle also shows you where the neurovascular bundle runs for the oral cavity. And this is something you'll see in the oral cavity lectures about when patients going up for oral cavity resection, can you spare one of the neurovascular bundles if you're going to do surgery or not? So with this tumor involving the muscle, you have the neurovascular bundle, which is cranial nerve 12 is medial to this muscle. The lingual nerve is lateral, so you may get cranial neuropathies as well, and I'll prove that to you in a minute. So on MRI, I'm going to show you the normal hyoglossus muscle. It's nice and curvilinear. It's medial to the mylohyoid. I'll show you more anatomy right now. Here's the mandible on coronal imaging. The mylohyoid muscle attaches to the medial surface, the mylohyoid line of the mandible. It goes across to the opposite side. In the midline, you have your genioglossus geniohyoid complex, and in between the two is your hyoglossus muscle where your neurovascular bundle runs. Okay, let's look at this poor patient who has a normal mylohyoid, hyoglossus muscle, normal mylohyoid. This is tumor. This is a T4 tumor from the right tonsil tumor. And after treatment, their tonsil tumor got much better. They just got a little bit, I guess, lucky. Some of the tumor went down, but not much. And over time, they failed miserably. I'm not going to show you all the images, but I want to show you another trip up that I see a lot. So this is right hemitongue atrophy. You can see it's fatty. The tongue, the base of tongue particularly, is flopping back into the lumen of the oropharynx. And people commonly call this a tumor. This is cranial nerve 12 was affected by this tumor next to the hyoglossus muscle, and this is your hemitongue atrophy. Don't confuse that with tumor. Now, it's very important to understand the difference between a tumor that started in the retromolar trigone, which is oral cavity, which is a surgical case, versus a tumor that started in the tonsil, which can be surgical or radiation oncology. And that's why I'm going to bring in my one oral cavity subsite. If you take your tongue and you put it behind your last mandibular molar tooth, you'll feel on top of your mandible the mucosa on top of the bone, which is called the retromolar trigone. That soft tissue is right on top of bone, so it's not a good place to have a tumor. It can directly invade bone. But there's also other structures that are close by that make this also a bad place to have a tumor. The pterygomandibular raphe, which attaches to the medial aspect of the mandible, the mylohyoid, goes from mandible to the medial pterygoid plate. It crosses the retromolar trigone, the buccinator, and the superior constrictor muscles attached to it as well. But I'm going to show you a picture because it'll make more sense. Here's a patient with a retromolar trigone tumor. The tumor got on the pterygomandibular raphe. Since the superior constrictor muscle attaches to the pterygomandibular raphe, this tumor tracked along the superior constrictor into the tonsil. Don't confuse this with a tonsil primary. This is a surgical oral cavity case. So let's keep watching where this tumor went. As you go inferiorly, remember I told you that the pterygomandibular raphe attaches to the mylohyoid line of the medial aspect of the mandible. You can see the tumor coursing that way, and you can actually see bone destruction even without a bone window. Look at this muscle. This is mylohyoid. Look at this muscle. This is a fat mylohyoid. It's tumor infiltrated. If you don't believe me, look on the coronal imaging. Mylohyoid, fat mylohyoid, that's tumor. The important point here is this is all submucosal spread. It won't be seen on clinical examination. You need to recognize it on imaging. So I'm going to show you now a palatine tonsil tumor and want to remind you guys that between the internal carotid artery and the prevertebral musculature, you have retropharyngeal lymph nodes, and that tonsil primaries love to go there. And you need to look for that with your palatine tonsil tumors. Who else goes there? We talked about the nasopharynx, the tonsil, but a lot of people don't realize that hypopharynx tumors and thyroid tumors also have a propensity for retropharyngeal lymphadenopathy. I want to quickly cover perineural spread of disease. It's very important for head and neck imaging. It obviously has treatment implications. We commonly see cranial nerve 5 involved and less so cranial nerve 7. It's so important to understand that patients can be asymptomatic, but we can see the perineural spread before you recognize it on clinical examination, or so really rely on imaging. If the tumor is near where a nerve is, you want to image that. These tumors can grow inhomogeneously along the nerve, so it may look like it skips along the nerve, so it's very important that you image the nerve from nucleus to end organ, and it can grow in any direction you want. So here's an example of cranial nerve 5, V1, V2, V3 go into Meckel's cave. V3 does not go into cavernous sinus, it dies deep into O valley, and V1 and V2 go into cavernous sinus, going to the orbit, and then various branches. If you have a tumor on this cheek, you can see how it goes along the infraorbital nerve and make its way back to the brainstem. If it's on the hard palate, here's that pterygopalatine fossa again, which is rich in nerves and can give you tumor spread from orbit to hard palate to infratemporal fossa to nasal cavity to brainstem. If you have a chin lesion, it can go along the inferior alveolar nerve, or oral cavity tumor can go on the lingual nerve. So here's a patient that came to us from the outside institution because they had a cavernous sinus tumor and they were going to get a craniotomy for a biopsy. But if you look at this scan, you can see that V2 is too big and enhancing. They have to have both to call it. Cavernous sinus, it goes through cavernous sinus. Meckel's cave is not fluid filled. You can see it's tumor filled. This is the main trunk of 5. Main trunk of 5 looks like this, so this is definitely too big and enhancing, and also goes to brainstem. So we stopped the surgery because this patient had a skin cancer with perineural spread of disease. This person did not need a craniotomy. And I want to just take you through some perineural spread step by step and why I look and where I look for things. Here's an MRI pre-contrast T1 in front of the maxillary sinus right here. As the premaxillary soft tissues, you can see a person that has melanoma. And since this melanoma is right next to the infraorbital nerve, I'm expecting them to have tumor spread along this nerve because melanoma loves nerves. Where is it going to go? Along the floor of the orbit and then the pterygopalatine fossa behind the maxillary sinus. And look, on the pre-contrast T1 weighted imaging, you can see how the fat makes the tubular enlarged nerve stand out. And look at the opposite side. You should see a little fat, a little nerve, a little vessel, but not this big trunk. Now I give contrast because I'm going intracranially. V2 is too big. Cavernous sinus too big. Meckel's cave too big. This is perineural spread of disease, and this is how it looks on coronal imaging, the infraorbital nerve. This is V2 and the foramen rotundum, absolutely too big and enhancing relative to the normal right V2. Here's a patient with a base of tongue cancer. If you look on the MRI, you can see clearly the hyoglossus muscle on the left is fine, the right one's not. Why am I bringing that up? Because remember I told you that cranial nerve 12 and 11 and a branch of V3, the lingual nerve, runs with it as well. So this tumor went from base of tongue into the oral cavity. Instead of going on the nerve and jumped on the lingual nerve, instead of going towards the brainstem, it actually came down the inferior nerve. And how do I know that? Look at the pre-contrast T1 MRI, fatty marrow. Here's the normal inferior nerve. This nerve is too big, perineural spread of disease. Now sometimes we have, see I told you I'm going to talk about the pterygopalatine fossa. It is such an important structure. It's such a highway for tumor spread that I just have to keep showing it to you over and over again. Here's a patient that presented with a pterygopalatine fossa lesion. We couldn't see anything on the skin, couldn't see anything in the hard palate, nothing in the infratemporal fossa, nothing in the nasal cavity. So what could this be? This could be a nerve sheath tumor, could be lymphoma, because lymphoma likes nerves too. But how are we going to know? We need a biopsy. So here's the normal pterygopalatine fossa behind the maxillary sinus. I want to show you there's soft tissue here going through a widened foramen rotundum, going along V2 into the cavernous sinus and Meckel's cave. But how are we going to get in there? Well, again, pterygopalatine fossa is behind the maxillary sinus, in front of the pterygoid plate, under the greater wing of the sphenoid bone, filled with all these neural structures. So if you start above the zygomatic arch and go immediately with your needle, just I'm going to quickly, you can see the needle, I don't need to point to it. You can see how you make your way underneath the greater wing of the sphenoid bone and right into the tumor, and we're able to get an FNA and a core, and this was lymphoma. So this patient was spared a surgery because this is a non-surgical treatment type tumor. But to remind you too that don't forget your radiology colleagues that can help you out in getting tissue. And a lymphoma loves to jump on nerves as well. So we do have the same issues that you guys have also with residual and recurrent tumor. With the anatomy distorted, we have the difficulty of trying to figure out what's post-treatment change, what's tumor, and so on. But as most of you know, we like to wait at least 3 months before we get a baseline CT, a baseline PET, or baseline whatever for post-treatment evaluation, because you need to have the effects of surgery and radiation to complete, or you're going to overcall recurrences. So I'm going to show you an example of a patient that has 3 months post-treatment, has a right base of tongue tumor. It's too much soft tissue is left. We're worried about it. We got a PET. You can see that the fused image correlates to our area of concern. So PET helped us direct a biopsy, residual disease. Here's another patient with a palatine tonsil tumor level and lymphadenopathy, post-treatment PET. Everything got better except for one lymph node. And if you look at the post-treatment next CT, this lymph node is contracted, this isn't. This was resected, and this was a benign mixed tumor, pleomorphic adenoma. And why did I throw that in there? Is to remind you that parotid tumors, the benign ones, warthins and pleomorphic adenomas, are very FDG avid. Don't use PET to help you differentiate between a benign versus a malignant lesion in the parotid gland. Why am I showing you this? Because PET's our friend, but we got to realize how to use PET and not trip on it. So may I steal 30 seconds? Sure. Okay, 30 seconds, guys, sorry. So this is another case that was brought to me. This is a patient that had lung cancer, was treated at an outside institution. I was told that they have diffuse tumor involving their right parotid gland, and this is to remind everybody that FDG likes to go to the heart, the liver, excreted by the kidneys, but goes to the salivary tissues, so the problem here is not what you see, but what you don't see. This patient did not have a parotid resection or a palpable lesion, and so it's just it was just fatty atrophy. I was just going to show one trip up, or I'll get off. Yep, that's it. I want to thank you for your time and attention.
Thank you so much. Wonderful talk, don't you?